I know you guys hate me now.
Get up there. All right, so let's talk about transplant rejection. Transplant rejection is type what? Hypersensitivity? 4. Type 4. It's going to involve T cells. T cells. There's an incompatibility of the allograft. I say allograft because it comes from the same species, allo, but it's not an autograft because it doesn't come from the same patient. If it came from the same patient, it wouldn't be an issue. So there's a recognition of the foreign cells. So during the break, some of you were asking, I'm kind of confused. Like, I don't understand why in a type 2 or a type 3, you have an antibody that's binding to an antigen. Why is it doing that? Isn't it supposed to? Yes. But if it's a self-antigen, it's not supposed to. Why is it binding to a self-antigen? Because in clonal diversity, in the bone marrow, it was created, and it happened to be self-reactive, but you didn't catch it. And you released it out into the bloodstream, and if it's a type 2, then it goes and finds some tissue that it matches, the epitopes match, and it binds and it causes problems where it's not supposed to. If it's a type 3, it binds to something probably circulating in the bloodstream, like maybe a complement protein or a plasma protein that's there. Okay? And then that complex gets lodged different places. Type 4 is totally different, right? Type 4 is T cell mediated. So here we've got MHC incompatibility because the major histocompatibility complex that tells you you're you and me I'm me is going to identify my kidney in you or your kidney in me. And it's going to try to seek out and destroy it because it's considered foreign. The body doesn't have the ability to say it's foreign. However, it's a good kidney. It just knows that it's foreign. Okay, so we have mechanisms to try to trick the body into allowing it to stay. But you have to know at least some of the pathways in order to be able to trick it. So there's two main pathways. There's a direct pathway, which happens to be the main one. And then there's an indirect pathway. In the direct pathway, which is the main pathway that we tend to really focus on with our pharmaceutical therapies, the direct pathway obviously is a little bit more direct in the sense, and that's why it's named that way. The antigen presenting cell in the graft, right, that's what's getting donated, is presenting an MHC class 1 or an MHC class 2 that doesn't match your body. So your respective CD8 positive T cells, if it's an MHC class 1, or CD4 positive T cell, if it's MHC class 2, they actually get triggered. And in the category of the cytotoxic T lymphocytes, they end up doing this activity in the blood vessel of the donor kidney. The kidney is I picked kidney as the example because that's the picture. So this is the renal blood vessel of the kidney that's getting donated. And look, here's the CD8 positive T cell binding to MHC antigen, causing endotheliitis, inflammation of the endothelium. Well, they also come down here and they bind and damage, or they bind to the MHC class molecule on the kidney renal tubule of the donated organ. And then they cause destruction here. You can see these cells are being destroyed by your cytotoxic T lymphocytes. Okay? The CD4 positive T cells stimulate this population of helper T cells that triggers an inflammatory response. Right? That inflammatory response can cause issues at the level of the tissue. It can also cause issues at the level of the vasculature. If it's That's the direct pathway. The indirect pathway doesn't involve any cytotoxic T lymphocytes. It's only CD4 positive T cells. This one's a little different. This is the recipient or the host, whoever's getting the donated organ. Their antigen presenting cell finds antigen on the graft, brings it in, presents it to the helper T cell. Helper T cell stimulates inflammation and or the production of antibodies. Okay? That's the indirect pathway. So both of these pathways are going to lead to destruction of the donated organ, and you don't want that to happen. So what do? Well, if you back up to the last unit, this is at the level of the lymph node, remember that? This is a drug called cyclosporine, or cyclosporine, or cyclosporine A. There's a couple different derivatives of it. It's an immunosuppressant drug. So we have a whole family of immunosuppressant drugs. The one example I'm giving you is talking about how do you block the direct pathway. And there's a whole slew of other drugs that you could choose from and other strategies to block the indirect pathway as well. I'm just going to give you the direct pathway example. So cyclosporine, what it does is it's very commonly used in post-allogeneic organ transplants to reduce the activity of the recipient who's getting the donation. Their immune system goes down and reduce the risk of rejection. So the patient's on it chronically the rest of their life. The cyclosporine activity is that it blocks interleukin-2. So if you remember back here on our T cell, this is from the last unit, in this box that we blew out, this diagram, here is the antigen presenting cell showing something to a naive T cell. The naive T cell actually has to co-stimulate before it can create a population of effector T cells and memory T cells. If it never manufactures IL-2 to bind to the IL-2 receptor on itself, right, this is a autocrine co-stimulation, then this population or these populations of effector T cells and memory T cells never get made. So cyclosporine specifically blocks IL-2 production, and it's considered an immunosuppressant drug as a result of it. Now, if you don't have cyclosporine on board, what happens? Well, this is a donor kidney, and you get rejection. The antibodies that get made on that indirect pathway, the one that was on the far right, those are going to trigger complement to come in and even leukocyte recruitment. The direct pathway, the pathway on the far left, is going to trigger cytolysis of the renal tubule cells. The CD4 helper T cells, they're involved in both direct and indirect. They stimulate and help to propagate this type 4 hypersensitivity damage. In the vasculitis, the inflammation of the endothelial of the renal tubule, or of the vasculature that perfuses the kidney, or of the renal artery, you're going to have a local level of inflammation that will eventually clot off, and that's thrombosis. So the organ itself will stop receiving blood flow. The graft, that's the organ, gets this vascular damage. If you restrict blood flow to the organ, you eventually kill the organ. You get organ death. So look at the progression here, starting from the left to the right. So this is A, B, C, and D. In panel A, this is in the hyperacute phase, so the early phase of a kidney allograft. And you've got endothelial damage and early neutrophil infiltration into the glomeruli. So this should have this white space that surrounds the glomeruli, right? And all of these hyper pink pigmented regions are showing you areas of endothelial damage early on. B, you've got a tremendous number of inflammatory cells now. All of the purple dots are all inflammatory cells, mostly neutrophils early on. They're the first ones that get there, obviously. And then in C, you can start to see and appreciate some scarring that's starting to take place. So this is rejection showing the vasculitis, where you've got the smooth muscle cells proliferating in the intima of the vasculature. So this thickness right here is smooth muscle cell thickening. And as it thickens, you're getting this vasculitis type of scarring. And then over here, on panel D on the far right, you've got arterial sclerosis, where the vascular lumen, this is supposed to be a blood vessel, is replaced by proliferating smooth muscle cells. So this little white space right here is all of the lumen that's left. It should have been this whole thing. And this would be like the example of, not necessarily at the level of the renal artery, but probably higher up than the capillary or the arterial level. So it's showing you that the vasculitis is closing down. Eventually you'll get clotting or thrombosis of that narrow opening, and you'll lose the entire organ. Okay? Hypersensitivity and autoimmune diseases. So from a pathogenesis, how does this start? What gets this thing going? Well, we've got breakdown of self-tolerance mechanisms. That's what I've been trying to remind you of. Whether it's B cells or T cells, if they're not self-tolerant because they haven't been screened, then you have all these issues. And our autoimmune issues are a result of a loss of self-tolerance. There are some triggers, though, that can take place. So someone asked about genetics. So the genetics is a big component. How we make up the B and T lymphocytes. There are some potential environmental triggers in certain cases. So we've got genetic susceptibility, failure of self-tolerance mechanisms. This leads to self-reactive lymphocytes, whether it be or T cells. Okay? Then you put them in this environment, and they're going to do all the normal things that we already know they do, but they're doing it to tissue that you don't want to destroy. So if we look at another example, this is systemic lupus erythematosus, and we think about these environmental and genetic triggers. And keep in mind, there's 4 main types of lupus, but I'm honing in on systemic lupus erythematosus, which is actually the most aggressive of all of the categories. So you have systemic lupus, you have cutaneous, which is usually just isolated to the skin. You have drug-induced, and then you have fetal. So systemic is obviously the most aggressive. It's the easiest one to use as an example because it shows elements of all 4. Well, we find that there are some nuclear antigens. So something in the nucleus is self-reactive in these systemic lupus patients. So we have nuclear proteins that are self-reactive. We've inherited some susceptibility to being self-reactive. We have identified certain nuclear proteins or other self-antigens that are causing problems. And then, usually in these patients, there's some trigger point. There's a lot of times in lupus patients, it may actually be a really, really bad sunburn. And it causes the events to show up. Okay? And sometimes in MS patients, we've seen also a trigger that takes place. It could be a pharmaceutical trigger, or it could be a really aggressive illness. Okay? It could be a virus that comes in like mono and kind of whaps, or just really gives the immune system a really, really difficult time. And then one of these autoimmune disorders kind of shows up or manifests itself. So that would be an environmental trigger. It's not necessarily what caused it. Does that make sense? There's a difference here. So the trigger, like UV light or sunlight or radiation could help trigger this cascade of event, but it's not necessarily the cause. But you can't rule it out. So we've got two initiators. We've got genetics, and we have these environmental triggers. The cell destruction that takes place is a result of these autoantigens that show up. And just like a lot of the autoimmune disorders that we've already talked about, we're going to see some classic clinical results. So in this patient, this is a systemic lupus erythematosus. They're going to have this butterfly rash. This patient has this butterfly rash on the skin. You see this also in discoid or cutaneous lupus that's only at the level of the skin. But in this patient who has systemic, a lot of the other types of lupus symptoms manifest themselves there. It's also called a malar rash, M-A-L-A-R. This usually involves the skin only in those types of rashes. You get a lot of skin erythema, that's reddening of the skin, like what you're seeing right here. You get a lot of joint swelling. The reason for the joint swelling is a lot of times when it goes systemic, okay, you get a lot of problems at levels or areas of involvement where things get filtered and trapped. So this is a type 3 hypersensitivity, right? So you're going to have joint swelling issues, you're going to have potentially vascular issues, and you're going to have renal issues, right? Remember type 3? So systemic lupus erythematosus is a type 3 hypersensitivity that's pretty aggressive. It's one of the most aggressive examples we could show. You've got glomerulonephritis because you've got an antibody-antigen complex that's getting stuck in different places, like at the level of the kidney, in the joints, as well as in the vasculature. And so when it gets stuck in the vasculature, that lesion that develops actually starts to necrose over time. Now, what about the CNS involvement? Why do we start seeing manifestations of central nervous system issues in chronic systemic lupus patients? Well, the vasculature that perfuses the CNS also is affected. And so as that vasculature narrows, you start reducing blood flow to certain regions of the brain. Depending upon where it is, you may have different types of manifestations. Okay? Question?
What kind of cells do the proteins what type of cells have the proteins that are being talked about?
What type of cells have the proteins that I'm talking about?
Yeah,
Which
you know, you
proteins?
said that it's the proteins in the nucleus, or the antigens, sorry, the antigens in the nucleus.
So the nuclear antigens is saying that there's an antigen that's present in the nucleus, and either the nucleus codes for a protein that's a transmembrane protein that becomes self-reactive, or when that cell actually is done and that nuclear antigen is exposed, then the B cell recognizes it and starts making antibodies against that antigen. So it could go either way.
So it's not a specific type of cell?
No. This is all systemic means it's all over the body, right? So, and the reason it's systemic is because it's this antibody-antigen complex that's circulating in the blood somehow, and it's getting stuck in different areas and causing issues in all these different areas. You get skin issues, joint issues, kidney issues, vascular problems, and central nervous system problems. Okay? Okay, let's shift gears to rheumatoid arthritis. Rheumatoid arthritis is an example of a type 4 hypersensitivity. T cells are involved. You see here CD4 positive T cells specifically. CD4 positive T cells. So there's thought to be an erythrogenic agent, and we believe that it's collagen type 2. That's what the data is kind of suggesting. So at some point in your life, if you become reactive to collagen type 2, and you find collagen type 2 in synovial joints, Well, you find it in a lot of other tissues as well. It's a very common type of collagen. Okay? So the etiology now, we believe that there is a trigger, and it's collagen type 2. We develop these autoantibodies towards collagen type 2, and let's follow what takes place here. So we've got our antigen, collagen type 2, triggering this, activating CD4 positive T cells, and we've got sort of 3 different pathways, right? So the CD4 positive T cells in the joint, they activate B cells. These B cells start forming autoantibodies, and they deposit in the joint itself and cause injury. And I'll show you some pictures of what the pannus formation is and the fibrosis. Then the CD4 positive T cells release cytokines that trigger the activation of macrophages. So now you get macrophages into the area causing inflammation. The CD4 positive T cells also activate the endothelial cells that are in the joint. Those endothelial cells actually start expressing adhesion molecules to a higher extent. And those adhesion molecules that are expressed help to make it easier for the inflammatory macrophages to come out of the vasculature and into the joint. So we have an inflammation localized in the joint. That's what's going on here. So we got a couple of pictures. We got a schematic cartoon diagram here, and we've got 2 different histology slides. So let's look at the schematic first. In the schematic diagram, we've got a normal joint that's on your left. Right? Here's the normal joint. Then there's a line down the middle, and then here is a type 4 hypersensitivity rheumatoid arthritic joint. And the immune complexes that form, you can see they get lodged in here. And this pannus that grows in, is part of that inflammatory response that we were talking about. It's a mass of synovium and synovial fluid and synovial stroma that's infiltrated with inflammatory cells. It has some granulation tissue there. It has fibroblasts that you would find. And it starts eroding the joint. It erodes the bone. And as it erodes the bone and you stress the joint, you start getting bending to take place. And that's what ankylosis is. Ankylosis is a word that means bent or crooked. So as you erode the bone and you still have pressure, you start getting these bent joints. Synovial destruction happens as a result of all those inflammatory cells being present, the macrophages and the lymphocytes that are present. In figure B, in the middle picture is the hematoxylin eosin stained section showing all of the inflammatory nuclei that have infiltrated into the synovial fluid. All those purple dots are inflammatory nuclei. And then on panel C, over time, you're going to get lymphoid tissue that actually sets up because of the presence of all of the T cells. And all the arrows, the red arrows, are pointing to these lymphoid aggregates that are showing up. This is a higher magnification of this. So these are the purple dots that you're seeing over here, just in higher view, so you can kind of appreciate every so often you're seeing these lymphoid aggregates, collections of B cells, of T cells. Collections of T cells. Okay? So you get in the joints. Well, you also can get these rheumatoid nodules in the skin. And why do you get them in the skin? Well, they only show up about 25% of our RA patients. And they're associated with more aggressive or severe phases of the disease. But these nodules that show up in the skin are because you have collagen type 2 in the skin as well. And so that same process can happen in the skin as it happens in the joint. It usually takes a slower amount of time because the skin is not perfused to the same extent as the joint is. Okay? And so you wouldn't see these things manifest themselves early on. You'd also potentially see these nodules show up in the vasculature because you have type 2 collagen in the basement membrane of the blood vessel. Okay? And the jury's still out. There's some that argue it's type 3, some that argue it's type 2. It might be a 2-3 combo. But it's probably some collagen derivative that's triggering these T cells to respond. So what's the clinical significance? What happens? So what happens is you can see on your left in A, both of these are arthritic joints. One is a little bit more aggressive than the first. The one on the left is in one patient, the one on the right is in a second patient. The organs that can be affected: skin, joints, blood vessels, even heart, lungs, and muscles, where you would have collagen derivatives in all of those locations. The ankylosis is really only found in the joints because it means bent. Usually targets the small joints first, like in the fingers, okay, or the toes. It's typically bilateral, meaning it happens on both sides, okay, at the same time. This is different than osteoarthritis. Osteoarthritis is not due to an autoimmune process, it's a wear and tear. Right? Osteoarthritis could be found in elite athletes who pitch for a living. Okay? And they have osteoarthritis in their throwing arm, but the other arm's fine. If they had rheumatoid arthritis, they'd have it in both sides. That's bilateral. Okay? So it's symmetric, is another way of saying that. This rheumatoid arthritic factor, we've been able to identify in 80% of the cases. But that also means that 20% we can't find, is there really a rheumatoid arthritic factor present or not? Okay, so that's why there's still some arguments or some criticism of, do we really understand the process completely? But what I want to show you here is, these are obviously smaller joints, so you're seeing here this hyper coloration, the white, indicating areas of a lot of fluid buildup in these joints, so that's inflammation. If you look in this particular picture that's zoomed in right here, you can see how that inflammatory response starts to erode the bone away. As this bone erodes away, it's going to cause it to be less strong on one side than the other, and that's why it kind of starts to bend. Okay? This is the summary slide for this lecture that I was telling you about. I think this is a very helpful slide. It characterizes, I think, really nicely the different type 1, type 2, type 3, and type 4 hypersensitivities down in these columns. 1, 2, 3, and 4. It gives you some features. You can see for 1, 2, and 3, there's antibodies involved, and for 4, there's none. Because it's why? It's T cells, right? Transferred with antibody, 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 T cell. Okay? Here's some examples that we've talked about, like allergic, asthma, hay fever. Right? Here's some examples that we did not talk about that you could add into your basket. Here's systemic lupus, erythematosus, with the type 3. The type 4, like poison ivy. Right? Poison ivy and poison oak is like contact dermatitis. It's a B-cell stimulated response. It's not an allergy. Right? If you have, has anybody ever had poison ivy or poison oak? Yeah. Does it feel like something's chewing up your tissue? Right? So this is actually a type 4 hypersensitivity. It's not an allergic response to like cat dander or something. Okay? Or if you're allergic to peanut butter, you rub peanut butter in your arm, there'll be a red mark there. Okay, poison ivy isn't an antibody that's being stimulated, it's actually T cells being activated. So I think this chart is extremely helpful. Questions? Okay.